Yeah, so welcome everyone again to Leiden. And let me start by saying that we have to refer to one other person that brought Miriam and me together in the early days, Jaap van der Herik. And he said, I want to introduce you to this lady, but she's a force of nature, which appeared to be true. And he invited us to have to good Dutch tradition bitterballen in The Hague. And I think the rest is history. I mean, she took over most of what I was doing. Now, anyway, so this panel will bring some very distinguished medical doctors that are, unfortunately, none of them will be here because they're from all over the world. They will be either on video. I think we may have one live. If the person is online, we'll see that. We have a little bit more time because Miriam also drills her PhD students very well that they keep their time, or it get even shorter because we were supposed to start at 12. I think that's one of the reasons she asked me to do the last panel for the lunch, because she knows I will never be short of words to fill any extra space, but I will also make sure we end at 12:30 so you can go to lunch. But maybe we can even have some questions before we go out for lunch. Downstairs, I suppose. And of course, I'm also here tonight for the dinner. So if people have questions about the vision I will present at the end, that would be also possible. Now, let me say a few things before we go to the presentations, very shortly. It feels today really like everything in my entire career comes together. I just retired a few weeks ago. Not that people get rid of me immediately, but I have officially retired. On the 6th of September, I will have my farewell lecture, the official afscheidscollege, as it's called in Dutch. But it's so funny that today, one of my panel members is Professor Andrew Kitua. And I'm not sure he is actually online. He has a video, but it would be so great if he is online to say a few words. Because I thought that shouldn't be Andrew Kitua that I worked with on malaria so many years ago with Venki Lama in Tanzania, and it was his boss. And then I looked up his photograph, and like mine, he looks very different from this old photograph like me. He also has a distinguished gray beard, so he even looks like a professor, like me, a little bit now. But I worked with him 30 years ago because I worked for 15 years on malaria. That's why I lost my heart in Africa. And now it all comes back together after all these years. And I'm so proud of Vote on Africa. And I can be proud because I didn't do anything except that FAIR is my fault. That's another story. But this is probably the most important implementation of FAIR so far. And FAIR, as we saw in January, spreads over 400 disciplines, is no longer restricted to health at all. But we work with people on distributed and federated learning, with swarm learning, nature papers, and everywhere. But I would say, and I will come back to that at the end, that Vodon really is the most productive implementation network as it started in CoFair, took over and became Vodon Africa, and now Vodon African Asia. It's really the best thing that could ever happen to FAIR, and I use it all the time. And actually, I also abuse Vodon all the time because there is a lot of resistance against FAIR as well in the establishment. And in that sense, Africa has the same advances as jumping the cables and go, mobile immediately. That still some people think that Africa gets the crumbs that fall from the table and so on. So there is not this establishment that turns against FAIR. So a lot of people tell me, oh, it's going to be very difficult. Then I'd say, oh yeah, you think it's difficult? They already do it in Africa, finance, and that is very good. And so I use it all the time as the prime example. And I hope we will see more about that. And I will give you a vision at the end and then for discussion over lunch and so on, where we would go now after changing the V in Vodon. We'll get back to that. So with that, let's go to the speakers. I'll leave it to you and I think they are introduced by their CV online. So I will stand back for a while until we have had all the speakers and then give a vision for discussion.
Give me a technical moment here to switch videos.
So maybe while this is happening, let me tell you what I meant by the V of vote on changing. Ayla and I were talking yesterday at the reception, and she told me about it. And I said, well, that's a great thing. You remove the word virus from the name, and that's the way to go viral. Okay? So if you want to basically spread this much wider than just for the virus and just for health even, it's much better to replace that for value. So that's part of the vision I will see at the end.
Good morning, good afternoon. Thank you for inviting me to make this speech. The title of my speech is Digital Health Integration in Ethiopia, Experiences and Use Cases. I am 43 years old and I have been involved in Ethiopia's health system both as a medical student and as a resident specializing in internal medicine, as well as a practitioner, teacher and leader in the health system for more than 2 decades. During those decades, I have seen the Ethiopian health system going through various stages. Ethiopia was able to bring down maternal mortality, children's mortality, and mortality from common infectious diseases such as HIV, TB, and malaria. The backbone of this achievement was a work that was done at the primary healthcare unit level with tens of thousands of health extension workers or community health workers deployed to the villages of Ethiopia alongside the expansion of health facilities. However, despite all the achievements, the government noticed that the remaining journey was going to be an uphill battle without the use of appropriate data to understand what exactly was happening on the ground, to prioritize interventions by population, economic status, geographic location, etc. Data was also seen to be very important for planning, monitoring and evaluation. Even though the government sincerely believed in the power of having correct data at the right time, it had taken the government a lot of work to make the belief a shared one. Data was documented on papers and registers, collected locally and reported to higher level authorities. Using data at the point of collection for decision making was rarely practiced. The government of Ethiopia, in its health sector transformation plan, which came out about a decade ago, included information revolution as one of the most important transformation agendas that needed to be addressed to be able to provide quality and equitable health services to our people. Information revolution had 2 major aspects. The first one was data use culture, and the second one was using digital technologies to make the work easier and have easily accessible data for decision making. Information revolution has continued to be one of the most important transformation agendas of Ethiopia's health system ever since its initial inception. Ethiopia has deployed District Health Information System 2, also called DHIS2, for reporting purposes from health facilities and district health offices. Logistics Management Information System was deployed in several health facilities and hubs of Ethiopian pharmaceutical supply services. Electronic Community Health Information System, also known as ECHIS, is being implemented in many pilot districts. This is expected to provide community-level household data. Some big hospitals are deploying electronic medical recording softwares. Picture archiving and communication systems are also being utilized in a number of hospitals in the country. Human Resource Information System is being deployed, though at a much lower pace as compared to others. Very recently, mobile X-rays with artificial intelligence for detection of even asymptomatic tuberculosis, which is one of the most leading infectious diseases in our country, and for quick reporting in faraway places and outside health facility setting is being attempted. There are also attempts to digitalize data centers in regions. Ours, the region Tigray, has inaugurated its regional data management center recently. So, at this point, it's good to ask a few questions. Was a journey without any challenge? Have we overcome them? If there have been any, many challenges of course exist. To mention some of them, 1, cultural and attitudinal change regarding the value and practical use of data have not been fully achieved yet. Second, the governance of health information system is highly fragmented. Third, the use of softwares from various sources utilized for different purposes within a single institution or beyond are usually not interoperable. Fourth, data obtained through research, surveys, or projects tend to be poorly accessible, and ownership of data was always a questionable issue, even though there seems to be now a progress. Fifth, security of data is least addressed. Sixth, digital literacy is a huge problem among the older health workforce. Seventh, the ICT infrastructure remains to be poor, even though there are improvements. Eighth, the private sector is not well integrated into the nation's health information system. And the last one is limited funding is a huge problem in information revolution. Despite all the above challenges, I personally believe, so does the Ministry of Health, that we cannot return back. We have a lot of talented youngsters from our country working within the country and abroad, making a real difference. My colleagues from my former university college and teaching hospital demonstrated their capability in their Vodan work, which had a principle of having data that is findable, accessible, interoperable, and reusable. They did this when our region was engulfed in a conflict and had little to no internet connectivity, and of course, without salaries and walking to their workplace every day. The Ministry of Health, in its recent health sector investment and development plan, has once again put information revolution at the core of what it does. Investment in health should take integration of digital technologies into the system as a priority. We should do this for the sake of our people and in the era of huge risk for pandemics and antimicrobial resistance, of course, for the rest of humankind elsewhere. Thank you so much.
Was Amanuel. Asma will also speak from the slides.
Good afternoon. My name is Dr. Asma. I'm the MOH, I'm the medical officer of health in Kibera in Nairobi, Kenya. I'm also one of the physicians working with Vodan African Kenyan chapter. And today I want to discuss about the vision of African health data space. I'd like to share some of the experience as a medical practitioner here in Kenya. Thank you. So when we're looking at the role of a medical practitioner, where African health data space, I think the main concept of the African health data space is to create the unified digital ecosystem where we can have accessibility of health data shared and utilized across the continent to enable improvement of patient care, research, and also improve on our policymakers. In Kenya, you'll find medical practitioners are at actually the forefront of this transformation, where they are playing a crucial leadership role in shaping the future of healthcare through data. The uniqueness about the Kenyan medical practitioners is in this, they hold both positions. Basically, a healthcare provider is also the same leader within the healthcare system. So there is a daily interaction with the patient where we get to access a lot of data, clinical outcome, and also notice the epidemiological patterns and trends which enable you identify if there's any issue. And you find the most important and crucial data of this data and the value is the integration or the consumption of this data at the lowest level of healthcare system, whereby decision can be made and also project or activities that are geared towards evidence-based decision-making and improvement of patient outcome. So when we're looking at issue of vision and leadership in digital health era, we're looking at the leadership requires the medical practitioner themselves to embrace digital health technologies and data management practice, not only utilizing the EMR system and health information system, but also advocating for their standardization and interoperability. We're looking at adopting these tools to enable or ensure data accessibility, data accuracy, and also data that is actionable to be used. And for Kenya, our vision encompasses having improved patient care, where a patient can have access to patient complete health history, regardless where they seek care, will enhance continuity and also quality of care. So whichever part of Kenya you are seeking help, you should be able, or the attending physician should be able to access complete medical history of this particular patient to be able to serve them best. And we're looking at data-driven public health, where we have aggregate of data to allow real-time surveillance of diseases, enable rapid response, and also resource allocation. Had this been in place, issue with the current pandemic and the pandemic that has just passed, and even what we are currently seeing, the MPOX era, will have actually been minimized. The impact of these infectious diseases of emerging and re-emerging occurrence will have been low. And looking issues of research and innovation, where we are having health data to drive local and global research, fostering tailored to the specific health challenges within Kenya. Now, for each and every challenges and opportunity, though the vision is quite ambitious, there are challenges as data privacy, infrastructure, and capacity building must be addressed. Medical practitioners must lead in advocating policies that will protect patient privacy while also promoting data sharing. So even when the patient is able to access complete history, the attending physician in Kisumu attending to a patient who was seen or resident in Nairobi and be able to access this data, this patient should also be assured of that patient privacy for their data and their indicators that are to feel safe. And we need to advocate for those policies so that we can also protect our patient and also promote data sharing. And also we need to have training and capacity building initiatives that are crucial to equip our healthcare workers with the skill to operate within the digital space. A lot is happening with the AI and machine learning. So there's a need of our healthcare workers to come up into terms on understanding and operate within the digital space and how to use this data that is collected within our data science and be able to consume it and tailor programs and projects to ensure patient outcomes are improved, and also new way of managing and treating comes in. And for that, I'd like to say thank you very much for the opportunity to speak and share experience here we have in Kenya. Thank you.
That was Dr. Asma from speaking from Kenya online. And the next speaker is Professor Andrew Kitua. I don't think Professor Kitua is online, so we will play the video. Professor Kitua, if I'm wrong and you are online, please feel free to introduce yourself as we go to the video.
My name is Andrew Kitua, the Deputy Vice Chancellor, Research, Innovations, Consultancy and Extension at Kampala International University. I feel greatly honored, and it is my great pleasure to be speaking here today on Modern Africa, a pioneer for African health data space. This is a novel initiative to comprehensively harness African health data and make it findable, accessible, interoperable, and reusable, allowing it to speak with and about communities, groups, individual patients, to speak with and about health systems, the health workforce, and to guide policies, practices, and prioritization. In allowing data to timely speak with and about communities, groups, and individual patients, it enhances timely communication to the communities about their health status, conditions, and risks, and motivates communities to have positive change of behavior, traditions, and practices. It also enhances timely risk communication and appropriate communication, as well as best practices and effective interventions available for communities to use. In making data speak timely with and about health systems, it also enhances equity through updated knowledge, where the health systems knows where the services are available and where they are not available, who is accessing health services and who is not accessing health services. It informs about resource allocation, and it also informs about how effective interventions are performing. In making data speak timely with and about health workforce at the point of care, it allows health workers to experience the value of data that they continuously collect. It therefore motivates them to understand the meaning of the data they're collecting, and this data helps them to improve their services, to work diligently in their services, and also to understand their problems and communicate them appropriately to the higher authorities. In making data speak to and with policies and policymakers, it allows appropriate policies and practices to be developed and implemented. It allows appropriate investment for health, prioritization for health, and efficient utilization of the limited resources we have. The outcome of all this process and the new initiative is better health outcomes for African populations. It will transform Africa from high disease burdened continent to a continent where populations enjoy living free of disease and ill health. This is making huge economic savings through appropriate and optimal use of data. Data is wealth, and when data is harnessed and used appropriately, it will improve our economic status. Ladies and gentlemen, we are therefore witnessing the safe harnessing of health data for huge health transformations in Africa, and also for better economical improvements in Africa. Enjoy the rich conference exchanges. Thank you.
That was great, and it's also nice to see that Andrew and I now fully agree. In the malaria days, we had a lot of disagreements, scientific disagreements. So I think I don't want to add anything to the vision of the medical practitioners that we have seen so far. What I would like to spend a few minutes on now is to take you maybe already a little bit into the future, or at least the vision for the future. But coming back to the past first. So when I was appointed professor here in Leiden, I had a somewhat peculiar title for my inaugural speech. And that was "Knowledge is like love. it multiplies when shared. Okay, so if you share love with somebody, nobody loses. If you share knowledge, nobody loses. It's a renewable resource ultimo. And that still haunts me because ChatGPT, so-called AI, of course not AI at all, when it first was asked to write my CV, it says I'm a major expert in love. So I put that immediately on my CV, of course. If anyone has any questions about that topic, come to me later. But of course, that was one of the proofs that the thing is just hallucinating. But anyway, just to teach you a little bit, I will have my my farewell lecture on the 6th of September now, after so many years. And there the title will be, and I won't go into that too much now, Data, Biology, and Pianos, and how they all relate. So we will so if you want to listen in, you're welcome. Just let me know. You'll get the link to register, either being there physically in the beautiful academic building in the center, and we have a whole symposium around it on the 6th as well. But the 5th is also important. We have a new institute, which will also be my post-pensionado, busy therapy, and that is called LIFES, the Leiden Institute for Fair and Equitable Science. And this is also a result from a meeting we had almost exactly 10 years after FAIR was conceived here, as Miriam said, in 2014. So in January 2024, we had another meeting. Francisca was there, Miriam, several others here in the room. And it was amazing, showing that FAIR has spread over hundreds of disciplines all over the world. But as I said in the beginning, I think hardly anywhere it has been implemented so correctly and so thoroughly as in Vodan Africa. Because Roche even came up with the term fake fair, and we also have a term called fair washing now, because the funders and policymakers are now requiring fair. So everybody's, yeah, we are doing fair. We put a DOI on my PDF. Now I'm fair. No, you're not. So the interoperability part of FAIR, and that is a link to this picture, I now consider as the machine knows what I mean. So it's extremely important if you want to succeed in the future of Vodan and the African data space, health data space, not only health, I hope. Again, you'll face exactly the same problems as in the European data spaces, in the European health data spaces. And I will end by saying that I think you're probably ahead of Europe here. Now, what we need to do, and this comes back to many of the presentations by the PhD students, again, the hourglass model. Sorry for the mix-up between interoperability between Keynote and PowerPoint, but okay, it's still readable. It looks much more beautiful in the Mac, of course, as usual. So the hourglass model indeed is minimal standards in the center, TCP/IP for the internet, and maximum freedom to operate in both directions for infrastructure and applications. We heard already enough about that. I won't go into details. So how do we translate that to the Internet of Fair Data and Services, which is the ultimate idea of the European Open Science Cloud, the African Open Science Platform, and so on? Essentially, we now have three components. So I sort of made this into a propeller years ago. And again, there is a center in the propeller that makes it all work. And that is that you have your data somewhere. And as we heard a lot, in principle, they stay where they are under the jurisdiction where they were collected for safety and all these other reasons we heard about. We have the algorithms, the trains visiting the data, but also you need local compute power to run the algorithm. And not all African institutes have that. Not even all Dutch institutes have that. So that's the difference between a fair data point where you just have metadata of data you offer for visiting. But if you want to run complicated algorithm, not simple ones, just looking for a side effect or whatever, but if you want to really work on a complicated analysis of data like we want for the Human Immunome project that I'm involved in very strongly now, it can only be done by distributed learning over very sensitive omics data to find out what the immune system is all about. You better have your compute as well. So you need to inform the train whether there is enough compute locally to actually run the algorithm. So the next slide, can I do that myself, I suppose? Yeah. Is giving that a little bit in this metaphor of the personal health train. You have trains which is, in many cases, a high-speed train that has already been pre-approved by, for example, HealthRI in the Netherlands, but it could also be Vodafone, of course, or the Human Immunome Project. Then you have fair data stations, and some of them have compute, some of them don't have enough, and sometimes you have to move your data temporarily to a local, place where there is enough compute. So the idea is now that what is more or less the equivalent to TCP/IP in the internet is what we now call a library in the center of this propeller, or the new three-dimensional hourglass. Sorry, let's go back. And essentially that library that is fully open source, and we can build it all together, so you can be heavily involved, contains every assertion or a template for every assertion a train ever has to make to a station, or a station to a train, including consent, including the simplest one: this train is owned by Roche. So we know Roche is a company. Are the data available for commercial use or not? Consent level. What data model did I use? Is it FHIR? Is it OMOP? Is it, what? So everything that is needed to make any train developed by anyone interoperable with any station is possible based on rich metadata created based on the templates in the library. And now we don't care which data model you use as long as it is compatible. We don't care where you store the data, whether it's in Amazon or in a private cloud or even your personal health environment. So this is one of the goals of LIFES, and we have lots of people already that want to be involved in this. So the vision is that we do data visiting. We do this together with CoData, with the World Data System, with all repositories, with the International Science Council, Global Open Science Cloud, African Open Science Platform. And so far, Vodafone was not very much involved, and I didn't really have a feeling how to do that precisely. But recently we got a very interesting opening here. Namely, we have the ambition. So basically the two lines of LIFES are as many fair data stations as possible in the world to be visited for particular purposes, and this library. Those are the two key businesses that we want. We already have many partners who want to join. It's a public-private partnership, an association soon. Anyone can become a member. We can discuss details later. And the idea was that we have three sorts of members. Users, so Roche, Bayer, a lot of pharma companies, but also universities say, I want good services around fair. And I want to be sure that I don't get fake fair. People say, yeah, we can do it, and then they fail. The second category was ASPs, application and service providers. We discussed already yesterday. You could do training as a service, verification as a service, data stewardship as a service, etc. People can do that business also in LIFES, in a public-private partnership. It will never restrict them in anything they want to do. But the most important one is the sibling institutes. Because even if you look at the logo, the L from Leiden is sort of outside the logo. You can replace that by anything. And we have an internal joke here that the University of Twente is one of the founders, and they decided that if they would call it Typhus, it would not be a nice name. So they decided to join the Leiden. But you can remove that L and put at, wherever you want to have a similar institute. So all the sustainable development hubs that the International Science Council is now setting up will need LIFES type environment, to do fair, to make data interoperable, and to make it so flexible that everyone can join the ecosystem. So this sibling institute idea that came up was actually focused on geographical entities. Like we already have more than 20 countries who want a similar thing, from the USA to Brazil, India. And for example, India works on tigers. It's not at all health, but very sensitive data. Because if they publish the data of the hidden cameras photographing the tigers, be sure they are killed the same afternoon by the poachers. So don't think only health here. But suddenly, and here comes the opening to the African data space, but also to Vodafone as such. suddenly we had, for example, Pistoia, which is an alliance of all data scientists in the pharmaceutical industry. They have like a lot of partners in most of the pharmaceutical industry. They want to become a member as a sibling institute for the pharma. They said, why do you restrict this to regional or geographical boundaries, like an institute in Brazil or an institute in Kenya? So we said, okay, so maybe you can take care of the pharma, and then WDS it can be take care of the repositories around the world. So you could imagine that we also have Vodon, or the African Data Space, together with the African Open Science Platform, just taking care of Africa. So on the 5th of September, we have a meeting on the first networking meeting of LIFES, and two ladies will be there that have major grants to connect Africa. Those are ARISE grants from the European Commission with lots of money, and they both come. I hope you'll meet them, Miriam, and whoever can be there. And they have already connections in 34 African countries, and one of the goals is to connect them to the digital highway, whatever you want to call it. So I think we have a mechanism now with maximum freedom to operate for everyone that uses this library to tell which choices they made according to FAIR to make things operational and interoperable, rather than forcing one particular implementation, as you heard in many of the presentations. So, final thing, and then we have some time for questions. That's nice. So please ask questions to whoever you want, not just to me. My vision and my dream has always been to get away from this crazy idea people have about Africa. I already published on the post-colonial syndrome in Science, with Andrew Kitua and other people many years ago, that why not assume that because there are less vested interests, maybe, Africa could at least co-lead this initiative. And that was triggered when Miriam said at the beginning of this meeting that if you are not online, almost you don't exist nowadays. So then I thought, hey, Homo sapiens is well known to have spread from Africa, the out of Africa theory. So maybe we should repeat that and make sure that Homo digitalis, the new species that's coming up, is also spreading from Africa. Okay, so that is the very high overall vision. And I think we can do it by joining forces and become a network of networks and simply bring critical mass together of people that implement FAIR the same correct way and not in a fake FAIR way. And if we honor this maximum freedom to operate, so we don't care for one particular terminology system, as long as they are mapped properly, you can use multiple, and that's where FAIR Connect comes in, where we publish all this. I was proud to see one of the articles already in FAIR Connect that was shown today, that we publish our FAIR implementation profiles, we publish the choices we made, so machines can understand what we did, and therefore we create maximum interoperability around the world. That's the next vision. And the African FAIR data space, if that becomes a success, that will be the biggest thing for me to rest my head after I've had a long career. So hopefully this inspires you to really be bold in your vision for this African FAIR data space. And you're all invited to join online, or there's still some spaces also physically at the 5th and the 6th of September. If you happen to be close to the Netherlands, we already agreed with some people to come. And now I would say, shoot at it and ask some questions, because we still have 8 minutes before Miriam told me, don't go over time. We need our lunch at 12:30. So that's also important. It was a long session this morning. Are there any questions? Don't be shy. Huh? You can just switch on your microphone and ask a question. And not only to me, huh? Miriam, there's lots of people here that you can ask questions to, including the PhD students.
Yeah. Or it doesn't.
Right, sure. Just in case.
Yeah. No, thank you very much. My name is Kwesi Buahine. I'm from Farm Access. It's in Amsterdam. I'm really inspired by the work that you're doing. You know, I compare this to what happened with the mobile technology 25 years ago, when, there was nobody, but somebody has to do it and demonstrate the value. And then we used to only use mobile technology to make a call until Safaricom came and demonstrates that you can actually use the technology to do payments. And then you see in Africa that, everybody is doing it. And actually, mobile payments have become the most viable part of all these telcos. So I see the comparison here where we're all talking about health data, but somebody has to do it. And the fact that you've been able to bring together, I think, 80 healthcare facilities across the various countries, I think is critical. So I don't know whether it's a question or an observation. I think that the value of data, so what you're doing is really important. How do you organize data to create the value? But I think another level of conversation is more about the critical problems that we are solving, right? And I think that's making the link between the two is critical. The doctor from Ethiopia mentioned how they've been able to use that to improve mother and child care. So just for your own perspectives about what you consider to be the fundamental problem that we need to address with data. And of course, Europe, Africa, I guess we are all dealing with more or less similar issues. So just to get your views on that.
Well, maybe first take a step back on your first remark. One of my gurus, and he was also at the original FAIR meeting, is George Strawn, who started NSFNet before the internet started. And he chose TCP/IP against all odds, And he told Bert and Eric and me from the beginning, follow this hourglass model, don't tell anyone else what to do, create critical mass, choose minimal technology only, and that's the only way it works. And Tim Berners-Lee would say the same for the web. If he would have gone anywhere beyond HTTP, probably it would never have worked. But also the use. Nobody could foresee what the internet would become in the days of NSFNet. The boss of George is even on record to say, do we ever go and give out more than 100 domain names? Because they were connecting 100 universities, and then it boomed. So, but also it yielded the smartphone, and of course, many of us are using it now, but we also know it's a big threat to the next generation. So one of the things I will say in my farewell lecture is I am not afraid that AI will become conscious and human. I'm much more afraid that because we rely on it, we become more like robots. So we have to be very careful that FAIR can be very beneficial and democratizing, but it can also have very negative side effects, that people abuse the data, okay? So our biggest challenge, I think, is that's why we have the E in LIFES as well, and it was part of our meeting in January. We spend the whole day on equitable access. And we defined it after a lot of discussion that if the question is legitimate, yeah, and it doesn't violate consent of the data wherever they are, there should in essence be no difference whether the question comes from Harvard or from Kampala or from Uganda, anywhere. And I think in Vodon it was shown already in one of the early implementations that the same query that was started in Leiden or in Uganda came back with the same results. So I think the equitable access to knowledge, not per se data, because in the end we want to exchange knowledge, not per se data. But if you don't have the data to support the knowledge, you're nowhere. So I think making sure that we do not, again, widen the digital divide by this new technology, but close it. I think equitable access to information, data and information and knowledge is the way forward. That's what I always believed in my whole career, and 10 times more important than money, for example. So that's our biggest challenge, to ensure equitable access. More questions? Miriam,
Yeah.
last 2 minutes for you.
Thank you. Thank you very much, Barend. That was really brilliant. Thank you. So to conclude and maybe to go back to your question, which I think links also very much to what Professor Kitua was saying, is that in Vodan we have now experienced that there are 3 separate streams that are very important to separate. And I think all of the PhD students in different ways spoke to those. So the first stream is that where data is produced, it must have value for those persons that that data pertains to, and for the place where that data is produced. So in the context of the work of Solid, where we're talking about personal data pods, etc., this is my data, and I govern my data, and I can make decisions about my data. In the context of the health facilities, where patients come to take services, the patients need to be able to benefit from better decision-making possibilities that is enabled by this data in the health facility for the clinicians and for the health workers. So Samson, Johannes referred to that as the personal health data train. So this data, which is produced only one time as semantic machine actionable data, has a certain application and certain access and control, privacy preservation requirements and regulatory needs that fit in that frame. And where the objective really is, and it's very important objective, that the data is first of all there to enhance something, to bring some value to the relevance of why this data is produced in that context. The second one is the ability across different places, and that is where Putu referred to the synthetic data. Now, if you take, of course, synthetic data makes no sense if it is in the relationship between the clinician and the patient. It has to be real data. But now, if you take insights out of that across different pods, like you're sitting in this beautiful pod here today, then synthetic data can be very useful, because then you are looking at trends. And then the production of synthetic data in each of the federated spaces can mask the personal privacy details that you don't want, but what you do want is to strengthen the ability to take insights from across these pods. And so Dr. Amanuel was speaking about that, and Geto is working on that. How do you enhance the decision makers from a regional health bureau in Tigray or Dr. Asma in Nairobi to understand the trends, the prevalence, etc., and to become enhanced by the data for stronger decision making? That's that level. And then the third level, I think that came out in the slide that that Misha showed, the last slide, and it also relates very much to what Barend was speaking about in the context of LIFES, is that the data space with a maximum of freedom of operation for curation and a maximum of freedom for the operability of this data needs to have some standard that allows the data spaces to speak to each other. And we can make choices in each of the communities. I mean, that has always really been the point of departure of how FAIR was a group of communities that would grow and use each other's resources as they would grow. But within the context of these communities that have this ability to interoperate, that is where now we are really speaking of data spaces. So the Vodan community, it exists. We can do these things within the Vodan community at all three levels. But now, if we in Vodan together with ODC or with Inspire, the different networks operating on the African continent with other vocabularies. Now, how do we operate at that level? That is the data space, and that is extremely relevant because that is where between the disciplines and between the community choices, we are able to allow third parties to benefit from that totality of data that is curated in different fashion with different choices. And that is very important because that is where we can start to begin to see that the data space is our new space for research. If you want to understand the side effects of this vaccine or that vaccine, you can actually begin to see how you can implement that in the data. And that is the third step. The first step, I can confidently say, we do. Samson, the speaker, the first speaker of the PhDs, he has modeled the decision-making on the rare resource of neonates intensive care units in Tigray from risk assessments generated from models done in the data. So that one, decision-making in the hospital is enhanced by fair patient data over which we can run the models. We can also run these models in other hospitals because once we have the model, we can bring it to Nairobi or we can bring it to somewhere else. So that one we do. The second one is the one where Rudewan is leading our work because that is where across the federated spaces, the distributed spaces, we are now able to look at trends, population health trends. What is happening here? What is happening there? Where is Mpox emerging? Where is it becoming prevalent? So that is where the masking through the synthetic data becomes very important because this is not about personal data. This is about trends across. The third one is really, we are at the step of the third one. And the third one is incredibly important because that is where we now transcend from services and decision-making into science. And that is where the vision of FAIR came from. It came from data is the key resource of science. How do we make that available as a resource? And that one is also very important because that is what is going to make it sustainable. Because if data has value, then we should be able, through this desire for using the data for queries, for research, dynamic queries, customized queries, that can generate new resources. And that is where the data space becomes a sustainable place, also a sustainable place where we are able, through the products, to regenerate resources to pay for the services to expose this data in the appropriate way and to produce this data in such a way that we know the quality of this data. So in order to have a health data space, there are services that need to be run over it, and that needs to be paid by the relevance of this data to third-party users. And so these three are really critical. So the first one we can do, and we must do it, because it really is critical for the work in the health facilities. The second one, we can do it, and we must do it, because that is what we know from COVID. We had Omicron, we had no idea. Did it come from Africa? Did it not come from Africa? Nobody knew. So the second one speaks to that. And the third one we must do, because that is the future of science. And that is where we are able to get the conundrum together of how do we pay for this? How do we make this sustainable? And the new questions in the old data, with that we can square that circle. So with that thought,
Miriam, can I say one thing about the last point?
You have 30 seconds.
Yeah, no, it's just basically one sentence. What you just said about the third point, one of the things that is important that Vodon is focusing mostly on real world observations, data from practice, and so on. What we also see is that you want to combine it with established knowledge and experimental data. You keep them separate. So one of the participants in LIFES has already 2.5 billion triples mined from 275 databases. So whatever pattern you recognize in real world observations, you can immediately do the research and what would it mean according to everything we already know. So I think that combination will be also the next step.
Yeah, in the third arena, you have the data from different disciplines. You have the routine data from patients, but also, as Aliyah showed, the research data of our colleague Meta Rustenberg on the vaccines. So that is where you can begin to combine different types of data. And we will still need to do a lot of research, actually, to see how exactly we can make that. Eric knows. It is one thing to think, oh yeah, okay, they are interoperable, but what is the point of that? So that is when you have different types of data, that's a different question altogether. But the whole really point of the third one is that you have a data space that is larger than just your community, and in which you can get third-party interests in. And that has always been the point of FAIR. That has always been the point of FAIR. But if we speak about the Internet of FAIR data and services, then we need to never forget the first and the second layers. Because if we do this just for the sake of science, it can't go anywhere. Data, if it has value, it must hold that value, first of all, to those to whom that data pertains. And that is a very European thought about the ethics of data. That is why Europe came up with GDPR. That is why it comes up with the AI Act. And that is also a very African agenda. We'll hear it in the afternoon, because data sovereignty in Africa matters. And so that is where, if now we go into the geopolitics, that agenda between Europe and Africa matters too, because we came from a different model in the United States, where all of the data, whoever had the data, could do whatever he could do with the data, whether it's Facebook or whatever. And that model is now being negotiated with this alternative vision. On the other side, in China, the government can decide everything you want to do with the data. Is not a European ethic-based program. So what we, I think, can do here, and that is why it's very good to have Honorable Minister there and to have the President of the PAP later, is that we need to have a global vision on the data space in terms of the core ethical values. And I feel that as Europe and as Africa, we really have a lot to offer, even if we are the junior players in the economic, digital, global current architecture. But what we have to, what we can contribute is the standards with which this global architecture operates, and therefore who can operate in this global architecture. So with that, we'll hear that later. I'm sure Elizabeth will speak to this point. And so I need to let you go and make sure that you have time for lunch and exchanges, etc. I look so much forward to the afternoon program. There are so many of you that we'll hear in the afternoon. Thank you for coming already in the morning. All of the moderators, Barend, all the other moderators, all of the speakers, thank you very much. Thank you everyone online. Thank you, Kai, for doing all the technical. It was perfect. And enjoy lunch.